Good day, everyone. We will now continue our study on the disorders of the skin. So, beginning at this group of disorders, pre-malignant and malignant tumors of the epidermis. So, we will only study the first three because Merkel cell carcinoma is rarely encountered. This condition is characterized by the presence of dysplasia or disordered growth in the epidermis, and because dysplasia is already caused by a mutation, there is a danger for actinic keratosis to degenerate into squamous cell carcinoma later. So the major predisposing condition is chronic exposure to sunlight. And then aside from chronic exposure to sunlight, these are the other risk factors for the development of actinic keratosis. So usually, you will be able to see tan, red, skin-colored, rough surface lesion. And then with time, these lesions may become hard and produce this appearance, cutaneous horns, such as this picture shown. So this will develop from hyperkeratosis, excessive keratin formation. So under the microscope, we will be able to see the following abnormalities. So there will be dysplasia or atypia developing in the lower layers of the epidermis, particularly in the stratum basale. And then there will be hyperplasia of that layer, and then some patients may present with atrophic epidermis, but more common findings will include hyperkeratosis, parakeratosis, and dyskeratosis. We have already studied these terms in our first lecture. And then underneath the epidermis, we will be able to see elastosis in the dermis. So in here, you're able to see mild elastosis in the dermis. However, look at the stratum basale layer and stratum spinosum layers. So you will be able to see large pleomorphic and hyperchromatic nuclei of the squamous cells. That is this dysplastic change. Those are the dysplastic changes that will be seen in actinic keratosis. So the cells look like malignant cells already. And then in the stratum corneum, we will be able to see a hyperkeratosis and a retention of the nuclei, parakeratosis. Our next neoplasm is squamous cell carcinoma. So it is the second most common tumor arising on sun-exposed areas, second to basal cell carcinoma. These are the risk factors. Again, one of the common risk factor is chronic exposure to sunlight. So, squamous cell carcinoma usually presents with ulcerated nodular masses in the skin. Under the microscope, we will be able to see nest sheets of malignant squamous cells infiltrating the dermis and sometimes even the subcutis. On high power magnification, you will be able to see the malignant characteristics of the squamous cells. So this malignancy is highly invasive and it has a possibility to metastasize later. Now, our next malignancy is basal cell carcinoma. So this is the most common tumor that will arise on sun-exposed areas. So the good thing about basal cell carcinoma is that it is slow-growing and, according to Robbins, it rarely metastasizes. But actually, 99% of cases, we will not be able to see metastasis in basal cell carcinoma. So that the treatment provided for basal cell carcinoma will not anymore include chemotherapy. So it will only require complete excision of the tumor plus a good margin of normal skin tissue to make sure that there will be no tumor cells that will be left. So that management alone can provide cure for basal cell carcinoma. So these are the major risk factors aside from chronic exposure to sunlight. So individuals who are lightly pigmented, particularly the Caucasians, and are fond of basking in the sun are the most susceptible to develop basal cell carcinoma. So these are the other risk factors for the development of tumors of the epidermis. Remember, neoplasms arise because of mutations. So it is your assignment to read on the genes and proteins that are specifically involved or mutated in each of the malignancies that we have just discussed. Now, for the tumors of the dermis, these are the commonly encountered tumors of the dermis. So, benign fibrous histiocytoma is a benign neoplasm of these cells, fibroblasts and macrophages, which are specifically called by this name in the skin. So, the histiocytes are the macrophages that are residents in the dermis. Usually, you will be able to see this tumor, benign tumor, in the legs of adults with this characteristic appearance, solid, nodular masses in the legs. Under the microscope, this neoplasm is located in the dermis and this will display irregular or infiltrative margins, although this is a benign neoplasm. And then on high power magnification, you will be able to see the fibroblasts, which are more or less spindle in shape, and then they are usually adjacent to the bundles of collagen fibers that they are forming. And then, aside from the collagen fibers, fibroblasts, you will also be able to see sheets of histiocytes or macrophages. So there is no nuclear pleomorphism, there is no increased mitotic activity, there is no necrosis because this is a benign condition. So unfortunately, the cause for the development of this neoplasm is not yet identified. The malignant counterpart of benign fibrous histiocytoma is called by this name, dermatofibrosarcoma protuberans. So this is a well-differentiated malignancy which is considered as the primary fibrosarcoma of the skin. So, because this is well-differentiated neoplasm, it is slow-growing, although locally aggressive, and then almost similar with basal cell carcinoma, this neoplasm rarely metastasizes. So, you will be able to see nodules in this condition, particularly in the trunk area of the body. So sometimes they may aggregate, the nodules may become coalesced with each other to form plaques that will become eventually ulcerated. So under the microscope, we will be able to see these characteristics. So spindle cells with increased mitotic activity, and because of the growing mass in the dermis, eventually the overlying epidermis may become thinned. So this neoplasm originates in the dermis, so pushing the epidermis upwards and sometimes extending deep into the subcutis. This is the characteristic pattern that you need to be able to see under the microscope to come up with the diagnosis of this condition. Dermatofibrosarcoma protuberans. So the malignant fibroblasts are arranged in radial fashion, which is characteristically termed storiform pattern. So this is the tumor located in the dermis, extending into the subcutis, pushing the epidermis above it. That is why the epidermis becomes thinned in this condition. This is the low power magnification showing us the spindle cells, malignant fibroblasts infiltrating now the subcutaneous tissue, which is composed of adipose cells. On high power magnification, this is now the storiform pattern of arrangement of the malignant fibroblast. So, evidence of malignancy. Here, evidences of malignancy are nuclear enlargement, pleomorphism, and hyperchromaticity. And then we will be able to see mitotic figures, indicating that these cells are multiplying at a very fast rate. Now, for this group, tumors of cellular immigrants to the skin. So, the neoplastic cells here are not, as the name of the group implies, are not native to the skin. So they are derived from progenitors from other organs of the body, which eventually settle and multiply in the skin. So examples of this condition are Langerhans cell, histiocytosis, mycosis fungoides, and mastocytosis. Langerhans cell histiocytosis is also called histiocytosis X for short. So this condition is caused by the abnormal multiplication of the dendritic cells, neoplasm of the dendritic cells. So the clinical manifestation is highly variable. So it can present with a solitary, small to large nodular lesions, which may become multiple with time. And then on top of this solid papules or nodules, there may be development of scaling plaques. So, characteristic appearance of the nodules and papules in histiocytosis X. So, the lesions in the scalp are already presenting with scales. So the proliferation of the neoplastic Langerhans cells may be in diffuse pattern infiltrating the dermis, so such as this picture, diffuse proliferation of the neoplastic dendritic cells, or it may form granuloma-like aggregation such as what you have seen in tuberculosis, or the neoplastic cells may present with foamy cytoplasm or xanthoma-like cytoplasm. So, diagnosis via microscopic examination is non-specific. Okay? Because of these patterns and because the dendritic cells look almost similar with the macrophages. That is why after histologic examination, these tests need to be done. So in order to confirm the diagnosis of Langerhans cell histiocytosis. So immunohistocytostaining with CD1 antigen and on electron microscopy present in the neoplastic cells are these structures, Burbeck granules, which are specific for the neoplastic cells in this condition. So this is immunostaining picture showing positivity of the neoplastic cells with CD1 antigen. The golden brown pigments are the CD1 antigens. Another condition that will present a tumor in the skin secondary to migrant cells is mycosis fungoides. So this is a T-cell lymphoma that primarily arises in the skin. Okay? So primary cutaneous T-cell lymphoma. So which may evolve in time into generalized or systemic form of lymphoma. So this commonly affects this age group, more than 40 years old. So you will be able to see non-uniform lesions in the skin in mycosis fungoides. So it may present with scaly red-brown patch, or some patients may present with plaques, or some patients may form fungating nodules that will become eventually ulcerated, or a combination of all these lesions may be seen in a single patient. So this is a severe form of mycosis fungoides where the nodules are already ulcerated. Okay? So when patients present with multiple nodules, most of the time, many internal organs are already affected by infiltration of the neoplastic cells. So producing systemic spread of the neoplastic T cells. So Zizari syndrome is the term coined to characterize the seeding of the blood by the neoplastic T cells, indicating spread already of the neoplastic cells to many organs of the body. So clinically, patients will present with diffuse erythema or redness of the skin. So under the microscope, what you will be able to see is exocytosis. Can you still remember the definition of that term? So this is the basement membrane of the epidermis. So usually, the leukocytes or the white blood cells will infiltrate the dermis only. But in this picture, we are seeing leukocytes already infiltrating the epidermis. Exocytosis. So these are now the neoplastic helper T cells infiltrating the epidermis. They may be present in singles or in clusters, forming this aggregation of white blood cells, which is called the Potrier microabscess. And then, if you will examine the neoplastic cells on high power magnification, you will be able to see a corrugated outline of their nucleus. So the characteristic cerebriform nuclear appearance of the neoplastic cell, cerebriform or brain-like appearance because of the corrugation. So these are the identified causes for the development of this neoplasm, a prior infection with this virus, and other forms of mycosis fungoides arise secondary to still to be identified etiologic agent that can cause mutations in the T lymphocyte. So mastocytosis, as its name implies, this is secondary to abnormal proliferation of the mast cells in the skin, which may involve other organs of the body. So clinically, it may present with urticaria pigmentosa, the localized cutaneous form of mastocytosis, where you will be able to see single or multiple lesions, primarily seen in children. Now, the systemic form, in children, you will be able to see lesions that are localized in the skin. In systemic form, widespread form, this form is usually seen in adults and associated with poor prognosis. So clinically, you will be able to see small elevated lesions or papules, or they may become aggregated with each other to form plaques. In solitary forms, you will be able to see pink to tan brown nodules that may be pruritic or itchy or form blisters. So systemic involvement may include these organs, the bone marrow, spleen, and lymph nodes. So the clinical manifestations, the redness, the itchiness, and the development of the nodules, papules, and plaques are all secondary to the effects of these chemicals released by the neoplastic mast cells, histamine and heparin. Sometimes, when these chemicals are released in great concentration in the mucosa of the gastrointestinal tract or in the respiratory tract, they may trigger the development of bleeding. So remember, histamine causes vasodilation, and then heparin prevents blood clotting. So clinically, you may be able to elicit this clinical finding, Darrier sign. So, which is characterized by the development of localized wheal, which will develop after rubbing the skin lesion. And then dermatographism will result from dermal edema after stroking of the normal skin with heated object. So, okay. So, this is the characteristic lesion that will be seen in mastocytosis. Solid, elevated, erythematous lesion. So, under the microscope, the neoplastic cells will look like the macrophages or the Langerhans cells in histiocytosis X. So that special staining is required in order to identify these neoplastic cells as the mast cells. One of these stains is a metachromatic stain. Again, this condition results from the neoplasm of the mast cell. So, secondary to a mutation of this gene, c-KIT proto-oncogene. Now, for our next group of disorders, these are disorders that are characterized by excessive keratin formation in the epidermis because of abnormal maturation of the squamous cells in the epidermis. So, characteristically, this condition is called ectiosis. These conditions are collectively called ectiosis. So, ectiosis is the Greek term for ecti. It's a Greek term for fish, right, indicating fish. So it is secondary to impaired maturation of the squamous cells in the epidermis. And because of that abnormality, it will result into excessive buildup of keratin in the epidermis. So the thick keratin layers will provide the scale-like appearance, fish scale-like appearance to the scale. That's the name ectiosis. Fish-like, fish scale-like appearance. So this condition may develop as in acquired form or inherited form. Usually, the acquired form is associated with white blood cell or lymphoid malignancy or internal organ malignancy, where these neoplasms will release growth factors that will increase keratin formation and impair the maturation of the squamous cells in the epidermis. And then the condition is grouped according to its form of development, so either acquired or inherited, histology, and clinical characteristics. So the characteristic fish scale like appearance of the skin in ectasiosis. Under the microscope, you will be able to see very thick stratum corneum with excessive piling of the keratin protein. So this is responsible for the development of that appearance in the skin. So this third picture shows us the normal pattern of keratinization in the stratum corneum. So it will display basket weave-like pattern, which is lost in ectasiosis because of excessive keratin buildup. And because of impairment of maturation, okay, there is a problem in the normal detachment of the dead squamous cells in the stratum corneum. Usually they are detached every day, but in ectasiosis, because of the problem of maturation, they are retained in the stratum corneum, causing progressive buildup of dead keratinized cells in the epidermis. Okay, so there are many forms of ectasiosis. For this form, the X-link, so it will develop secondary to the deficiency of this enzyme, steroid sulfatase. So this enzyme is normally involved in the removal of the pro-adhesive cholesterol sulfate, which is present among these squamous cells in the epidermis. So aside from the desmosomes, which will provide intercellular junction among the squamous cells, cholesterol sulfate contributes to the adhesion of the squamous cells with each other. Now, deficiency of the enzyme that is responsible for digesting cholesterol sulfate will result into persistent cellular adhesion, so that the dead squamous keratinized cells are persistently retained in the epidermis. Acute inflammatory dermatosis. First condition, urticaria. So it is also called as hives. Clinically, what we will be able to see are wheals. These are erythematous or red, elevated, and itchy lesions. So these lesions usually develop secondary to the chemicals released by the mast cells. So commonly affected age group is 20 to 40. The lesions in urticaria will develop and fade within 24 hours. Okay, characteristic wheals that will be seen in urticaria. Under the microscope, what you will be able to see in urticaria is normal epidermis. There will be no abnormality that will be seen in the epidermis. The abnormality will be localized in the dermis. Okay? Evident in this picture are dilated blood vessels and edema in the dermis, which are all products of the chemicals that are released by the mast cells. Remember histamine? So that chemical induces vasodilation and increased vascular permeability, which will eventually cause the development of edema. So that's the redness, the swelling, and the itchiness in urticaria. So this develops secondary to IgE, dependent mast cell release of the contents of their granules, or type 1 hypersensitivity disorder. So triggers for the urticaria attacks are the following foods. So there are individuals who are allergic to chocolates, so crustaceans, crabs, shrimps. So the clinical manifestation of that allergic reaction is termed by this name, urticaria. So acute eczematous dermatitis will develop in different mechanism from that of urticaria. So urticaria usually develops secondary to type 1, immediate hypersensitivity reaction. Acute eczematous dermatitis will develop in the form of type 4 hypersensitivity reaction. So this hypersensitivity reaction develops secondary to exposure of chemicals. And then these chemicals are believed to bind to proteins in the epidermis. So because of that binding, the antigenic properties of the squamous cells become altered. So forming neoantigens, which will be collected by the dendritic cells of the epidermis, or the Langerhans cells. So these cells, antigen-presenting cells, after collecting the neoantigens from the epidermis, they will leave the epidermis or the skin, enter the lymphatic vessels, and go to the nearest lymph nodes to present the collected antigens to the CD4 lymphocytes. So during the first encounter to the neoantigen, there will be no allergic reaction yet that will develop. So that period is called the sensitization phase, where memory T lymphocytes are produced in the lymph nodes. During subsequent exposure to the same antigen, re-exposure to the same antigen after the Langerhans cells collect that antigen and present the antigen to the memory cells, the memory cells will become activated, they will multiply at a very fast rate, and go to the site of antigen exposure, where they will be releasing many classes of chemical mediators. So these chemical mediators are now responsible for the development of the signs and symptoms in acute eczematous dermatitis. There will be development of edema, vasodilation, the squamous cells will become detached from each other, and then with time, the epidermis will become stimulated to undergo hyperplasia again because of the chemical mediators that will be released from the delivered activated T lymphocytes. So with time also, the epidermis or the cells in the epidermis will become detached with each other so that edema will form within the epidermis. Clinically, this condition will present now with blisters. So, which is microscopically termed spongiosis. So, from the separation of the squamous cells from each other, resulting into the accumulation of fluid in the areas of separation, and then clinically, what we will be able to see are vesicles or blisters. And then after the blisters become ruptured, there will be crusting at the surface of the ruptured blisters. A severe form of allergic reaction is called erythema multiforme. So if you will dissect its name, erythema, redness, and then multiforme, many forms. Now this is a self-limited form of hypersensitivity reaction secondary to drug exposure or infections. So the mechanism is the abnormal activation of the CD8 lymphocytes, which are also called cytotoxic T cells. Because of that abnormal activation, the T lymphocytes are targeting and killing the squamous cells in the epidermis. And then later on, you will discover that the epidermis is not the only epithelium that may become attacked by this abnormally activated cytotoxic T cells. So unfortunately, the target antigen for the development of this condition that will lead into the activation of the CD8 lymphocytes is not yet known. So this condition may affect any age. So again, the major trigger for the development of erythema multiforme is drug administration. Okay, so particularly to these drugs. And then sometimes erythema multiforme may develop because of infections, because of the presence of underlying malignancy, or because of an autoimmune disorder such as SLE and polyarteritis nodosa. This is the reason why this condition is called by such name, erythema multiforme. So the red lesions will present with highly variable appearance. So however, prominent appearance of the lesion is the target-like appearance, where there will be dark red portion at the center of the lesion and then lighter red in the periphery of that dark area. So the central portion is darker than the peripheral portion because of the extensive degree of necrosis that will develop at the center secondary to the killing of the squamous cells by the abnormally activated CD8 lymphocytes. Okay? Electron microscopic examination will show the CD8 lymphocytes at the dermo-epidermal junction in the deeper dermis and producing exocytosis into the epidermis, infiltrating the epidermis, where they will be killing. So, clinically, you will be treating these conditions by giving the most potent anti-inflammatory drug, steroids. And because there is already sloughing or erosion of the epithelial tissues, patients are now predisposed to acquire infections. That is why, aside from giving steroids, you need to give also antibiotics. Now, for the next group of skin disorders, chronic inflammatory skin disorders. So, include psoriasis, one of the commonly encountered chronic form of dermatosis. So, this is an autoimmune disorder which will present with many types of skin lesions. So, pink to salmon-colored plaques with silver scales. characteristic appearance of the lesions in psoriasis. Pink or red colored lesions with silver or white to silver scales. So these smaller lesions may become fused with each other to form this large, very itchy looking lesions because of the extensive erythema that will develop in psoriasis. The problem with psoriasis is that it is a T-cell mediated autoimmune disorder. So these cells are involved in the development of psoriasis. The dendritic cells, primarily the CD4 lymphocytes, the CD8 lymphocytes, and the squamous cells in the epidermis. So abnormal activation, which will begin with activation of the CD4 lymphocytes, the CD8 lymphocytes, and then now eventually the dendritic cells will become activated, and then the keratinocytes will become activated. All of these cells will be releasing many types of inflammatory mediators, and growth factors. So these chemicals are now responsible for producing all the abnormalities that will develop in psoriasis. Under the microscope, these are the characteristic lesions that we will be able to see. So there will be leukocytes, particularly CD4 and CD8 leukocytes that will be seen infiltrating the dermis. So where they will be releasing many classes of chemical mediators, resulting into the inflammation of the tissues of the skin. Now, because of edema, you will be able to see areas where the dermal papillae will become very prominent. So inflammation of the dermis will push the dermis so that there will be areas where the epidermis will become thinned. And underneath, the dermis will display vasodilation and edema. So that when patients scratch their lesions, some patients will easily develop bleeding at the area of scratching because of the thin epidermis that will be covering the dermis that will possess dilated blood vessels. So bleeding may develop, and clinically that condition is called Auspitz sign. So, and then the diffuse infiltration of the dermis by lymphocytes, which may be accompanied by the neutrophils, is called by this microscopic term, spongiform pustule. And then the neutrophils may also become recruited in the stratum corneum. So the encircled portions are dark because they are composed already of neutrophils infiltrating the stratum corneum. Remember, neutrophils that numerous and that closely spaced with each other will form is the microscopic appearance of pus. So which is characteristically called by that term, Munro microabscess. And look at this portion of the epidermis. So it is thickened, acanthosis or epidermal hyperplasia because again of the inflammatory mediators that are released by the recruited lymphocytes. And then the scaling will result from hyperkeratosis, increased keratinization of the stratum corneum, and the redness will develop from the dilatation of the blood vessels in the dermis. Okay. Another form of chronic dermatosis is seborrheic dermatitis. So it is more common than psoriasis, and the lesions are characteristically seen in areas of the body with high number of sebaceous glands, particularly in the scalp and in the forehead. So what you will be able to see in seborrheic dermatitis are numerous macules and papules on erythematous yellow greasy base with extensive scaling and crusting. So similar with the appearance of dandruff. If the lesions will develop in the scalp and in the forehead. So under the microscope, we will be able to see spongiosis, edema within the epidermis, acanthosis, hyperplasia of the epidermis, parakeratosis, retention of the nuclei in the stratum corneum with accompaniment of neutrophilic infiltration, and serum at the ostia of the hair follicles. And then there will be numerous infiltrates of lymphocytes and neutrophils in the dermis also. The cause, unfortunately, is unknown for seborrheic dermatitis. So another form of chronic dermatosis is lichen planus. So this is a cell-mediated form of autoimmune disorder which is characterized by infiltration of the skin by the T cells and proliferation of the dendritic cells or the Langerhans cells. So this is a self-limiting condition, but there are cases where lichen planus lesions degenerate into malignancy. So characteristically, the lesions will be seen as pruritic purple polygonal papules. So purple polygonal papules that may display Wickham striae, which are actually formed by zones of hypergranulosis. So the lesions in lichen planus are usually multiple and with symmetrical distribution. Under the microscope, there will be dense lymphocytic infiltration in the dermis and in the dermo-epidermal junction. So there will also be degeneration and necrosis of the basally located squamous cells because they will be attacked by the abnormally activated lymphocytes and the saw-toothed pattern of the dermo-epidermal junction. So sebate bodies may be seen, which are actually necrotic basal cells in the dermis. And then there will be acanthosis or hyperplasia of the epidermis, resulting into increased thickness of the epidermis with hyperkeratosis and hypergranulosis, which will form the Wickham striae. So we will end this lecture at this point. So we will continue the study of the remaining skin disorders in our next meeting.